He recorded. Pragmatic approach of thyroid problems, especially the case discussions and different approaches in management of thyroid with clinical experiences. In last lessons, last interactions, we had some of the basics things, and directly we jump into the practical aspect. And in the last part of our presentation, there are very nice questions, very realistic, very pragmatic, and very problem-oriented questions are raised. And I believe I could able to clarify most of the questions in an expected way. And today, I'm going to start to discuss some of the cases which comes in the clinic. And by seeing such cases, often it gives a better idea what we can do in different type of thyroid manifestations. There are a large number of cases can be discussed, but I took some unusual presentations or some misdiagnostic presentations are the thing for today's discussion, because since this program is exclusively meant for thyroid, and you're already heard many speakers are by and large they spoken about the theoretical and practical approaches. So let me jump into the cases of it. So let's see, this is one case. A girl aged 14 came with this report. Her RBS was 87. Look at the serum T3 and T4. It was falls in the normal range, but look at the TSH level, it was 10.29. And more importantly, look at the TPO, that is anti-TPO, that is thyroid peroxidase antibody titer, which is also known as anti-TPO. Very oftenly check to know the status of thyroiditis, especially of autoimmune nature, which is supposed to fall less than 40. Now you can see this case, it is 600. And again the thyroglobulin, again another antibody test, which also shows significant increase in the situation. A girl just aged 14. So she had been consulted to a doctor with the above problems on the same day. This is 26/4/2017. On the same day, and this doctor prescribed 25 mcg of altroxin and asked her to review after 2 months. And so this was after 3 months. This was the condition. So after 4 months, actually, this was the condition of a mild thyroiditis, because she came to my clinic with this report, and she mainly complaining the disturbance in the memory, and she was also a little bit upset about the generalized growth. At least her parents were a little bit upset about the generalized growth. And moreover, they found her menstrual cycle is not yet arrived. So they came to me with these reports, and obviously when you suspect this type of high anti-TPO, we are expecting a condition called Hashimoto thyroiditis or autoimmune thyroiditis, and decided to check the thyroid structure. So parallelly, I started giving treatment to this girl. with our own medicine, Ayurvedic medicines, as we discussed before. And they found that there is still thyroiditis, that is, the inflammation persists. But very interestingly, the serum TSH levels declined. Serum TSH level declined later. And also importantly, anti-TPO also came down. Unfortunately, I forgotten to add that slide here. So anti-TPO also drastically declined from the original thing. So this is not very common to have at the age of 14. This is not very common to have a Hashimoto thyroiditis or autoimmune thyroiditis. Because at the age of 14 and all, obviously there is growth hormone will be increased, also as thyroid hormone also will be increased. And at this age, it is not very common to have a thyroid dysfunction. Maybe at this age, a girl can have polycystic ovaries or maybe some other comorbidities, but not thyroiditis. And she is under treatment now and withdrawn completely the thyroxine, and things are much better. So don't take this as a simple case of hypothyroidism. Look at the problem, severity of the problem, and such cases may need long years of treatment. So I'm looking for this case then from last 3 years, and now symptomatically better, growth is improved, memory is okay, like that. So this is a one case. So what I want to say in this situation, is how we should see case. So what I want to communicate by seeing this is that even though the modern endocrinologist simply prescribe thyroxine or levothyroxine, it's not enough that you just do that. Rather, try to understand the whole scenario, what is happening in the internal system. Like Chakrabani says in Charaga, Abhyandara Vigruti Parambara evam Vyadhi. So look at see the Abhyandara Vigruti Parambara and try to analyze. This is another case, very interesting case. One of my student, Ayurvedic student, who was treating the case. So she was communicating me through WhatsApp. So I just took that thing. So you see, for one patient, she had a T3 435, T4 21, and TSH is 0.01. So TSH is 0.1. You see that T3 is high. Normally, how T3 should be? Should be between 80 to 200 or something. Look at here, it is almost T3 is quite high, and T4 is only 21, and TSH 10. So since she suspected, okay, since she find this is a case of hyperthyroidism, she started giving medicines like Drakshadi Kashayam, Kanjanara Gugudu, and Dadimadi Kridam and Panchapolichomam. So I advised her that instead of giving these things, why don't you give Tiktaka Kridam Vidayadi, not Hamsavati Adikashayam, Kanjanara Gugudu? Okay, then later on she communicated me, sir, I have given Tiktaka Kridam and Vidayadi Kashayam, Uluchadi Kashayam for 6 months, for a longer period. And later, sir, now TSH level remains the same. T3, T4 levels improved in hyperthyroidism, but the TSH remains 001. So now allopathic doctor advised to do thyroidectomy. Any other options to avoid that? So I asked her to go for hospitalized treatment for this case. So instead of giving oral medication, why don't you advise, since this doctor is this my student and she's working in a very reputed Ayurvedic hospital. So I asked her to go for admission, make the patient to get admitted, do the certain procedures. So our IP treatment required. They are ready to do IP treatment also. Look at this, symptoms improved, weight gain, tremor, palpitation improved. Well, please suggest better options. So like that, such case, this case is very important because here this hyperthyroidism manifested due to improper management of hypothyroidism. It is very often people comes in the clinic with some of the hyperthyroidism symptoms. Most of the time don't think that this case is having hyperthyroidism. Rather, it is nothing but the improper usage of the levothyroxine in the right dose. It can also happen in the other side when people uses neomarcosol, which is oftenly prescribed drug for hyperthyroidism, also create hypothyroidism. So, whenever we have cases in front of us, never jump into a diagnosis that because of what this problem is. The first and foremost criteria we have to take is that to possibly exclude the physiological aspect of it. Let me give you an example slide. This will be giving a better clue for this. This slide, I'll put that slide first, so that this will be helpful for you to give a better idea. So, look at this slide. Suppose, suppose patient comes with TSH is, what is that here on the top? Okay. Okay. So remember this one. When TSH is within range, T3 is decreased, T4 or within range. What does it mean? It is very, very clear. As you can see, what does it mean? This means that it is an isolated low T3 often seen in elderly or associated non-thyroid illness. So, if you simply find anybody, an elderly male, in elderly man or woman, if there is a drop of T3 level, it can happen even up to 25% of the people. Why this T3 is dropping down? As I mentioned before, whenever free T4, that is the T4, which is by and large that hormone is available in the whole system, but only when one iodine is released from the outer orbits of that molecule, that is the tetraiodothyroxine, it can convert into T3, which is cellular receptacle, which will get into the inside the cell, acting, supporting with the ATP, and it can energize the cell and do performance. So what happens as the age passes, the T3 production from the thyroid gland may decrease from the normal range just by normality. That means an age-old person, 80 or 85, with a very isolated low T3, don't jump into a diagnosis. Okay, T3 is decreased, and TSH and T4 is, this is something, thyroid is dysfunctioning. Now we have to start with thyroxine. No, it's not necessary. It can happen. Obviously, it can happen in this many non-thyroid illnesses too. Again, another example. Simple increase of TSH. Very, very important. Very simple increase of TSH. But T3 and T4 is within range. Okay, if all of a sudden, if you find somebody is having TSH is 10, don't jump into diagnosis again. Isolated high TSH, especially in the range between 4.7 to 15, is commonly associated with physiological and biological TSH variability. Suppose if I go for a trekking in my hill station in Kerala, or if I go for a Himalayan trip, my TSH will definitely increase because my body demands more and more energy. If I walk 20 or 30 kilometers for Chaturtham, Chartham, my body may demand more and more energy, and my TSH will obviously go high. It's not thyroid dysfunction, rather it is simply body asking the whole system. There is a high demand from the whole system, and body is requesting, please increase the secretions of T3 and T4. That's all. And again, it may be a subclinical autoimmune hypothyroidism. Subclinical autoimmune hypothyroidism. Or it may be intermittent T4 therapy for hypothyroidism. T4 therapy, intermittent T4 therapy in the sense, there are situations where people get removed by the thyroid gland. So, when someone's thyroid gland is removed, they will have a iodine therapy. This iodine therapy may also produce us an increase of TSH. Or even simple increase of TSH may be of a recovery phase. You can very commonly see people is undergoing chemotherapy, people who is having hepatic disorders, people who is having renal disorders, and many, many things. So you are hearing an exclusive lessons on thyroid. So I believe you are all become specialists, not ordinary generalized practitioner, because you are attending a specialized program. So keep it in a point that don't jump into a TSH rise into a thyroid dysfunction. Of course, you remember in the last presentation, I made a simple box which give a simple idea how to diagnose. But this is the level 2 because today is the level 2 class. So I put things in a simple way how you diagnose. But what is behind this problem is very important. Suppose TSH is increased, but if there is a decline of T3 and T4, this is more alarming than if TSH is high with the range of T3 and T4, because it may be of many reasons. If there is a T3 and T4 is decreased, obviously we should understand that it may be due to a post-thyroidectomy, or people may be having radioiodine, or it may be hypothyroid phase of transient thyroiditis, or even chronic autoimmune thyroiditis. Obviously, at that point, you have to examine the neck. I believe most of your previous speakers might be explained very detailedly how to examine the thyroid in a very systematic way. So you have to examine the thyroid, keeping in a position, standing in the backward, palpating the gland in an empty mouth, then give a glass of water just like that, and ask the person, fill the water in the mouth, put the mouth full, palpate again, then ask the person to slowly swallow the water through the esophagus and oropharynx and esophagus. So what happens, there is a movement of the push of the esophageal push to the trachea, and in and around trachea there is a thyroid gland. So that thyroid gland will be more palpable comparative to empty situation. So you'll get a rough idea. Do there is a complete thyroidectomy happened, or a partial lobectomy, a lobe is removed, or whatever the status. Of course, many times nowadays these things are become much easier because most of the people are much aware of the surgeries. They may come up with post-surgical reports, then things are easy. But still, I strongly recommend you to not to see this type of reports first. Not to see this report first. First, you do your physical examination. Think your area of perception. Then look at the reports. Why? Because many times when you look at the reports, you already prejudiced that, okay, this is the problem, this is the prescription, this is the symptom. No. I personally, as an Ayurvedic clinician, I personally strongly recommend it, not only thyroid, irrespective of any case you get in your OPD, it is the ideal way is just not to see any of the reports what they have in their practice. I mean, the patient may have a file with all the prescriptions of the previous consultants. It may be including the lab reports, CT scan, MRI, whatever. But in my personal experience, I have been practicing from last 21 years. In my personal experience, I tried both the method. One side, you just keep away all the modern investigations, everything apart. You do physical examination, interactions, and arrive logically, you think, and arrive into a conclusion and arrive into reach into a prescription, write down that prescription, then you go through the report to cross verify that does our prescription is able to address the described report also. I put it another way also. I have seen many cases. First I see the report, then I am already prejudiced, then I write a prescription. But truly speaking, as an Ayurvedic practitioner, I like to recommend you to do the first way because this was more successful. Without seeing these investigations, without seeing all the medical reports, if I'm able to arrive into a conclusion and I'm able to arrive into a purest form of prescription, which was working better than the second one where we go through all the investigation report. Because once we go into the investigation reports, MRI, CT scan, whatever, it can add on values. You may get a confidence. It gives very easy for communicating with the patient. You may give a lot of impressions in front of the patient to give more details of the problem. Even you may feel more confident. Even the status of the the predictability of the disease too. But when you arrive at a prescription, situation is different. Because all these things are outcome of another medical science. Obviously, it is well and good. I completely agree with all the informations, but let that may not be a thing that can manipulate, that can bias, that can color our decisions. Because Ayurvedic prescriptions are not made for that. So again, back to the point, I strongly recommend if you are specializing or you are focusing on thyroid, just hear the patient, communicate with the patient, speak to the patient, what they want to say, do the examination. As I mentioned you, there are many simple techniques to do. So that's the point what I want to say in while when TSH is raised and T3, T4 is decreased. This is very crucial. There are situations thyroid become very dangerous situation. When a patient get unconscious, or imagine a patient got unconscious. Most of the time, people will think, okay, one of the possibilities hypovolemia or hypoglycemia or maybe many other things, maybe involving stroke, many things. But very seldom people think about thyroid coma, but it is not very rare. It's not very rare. It is happening many times that many people go for a coma stage, especially those who are in a thyroidectomy, undergone thyroidectomy, but not taken the medication properly. I'll come to that point later. So then comes the TSH when it's raised or within range. T3, T4 raised, T3 is raised, or T4 is raised or within range. Inherent antibodies to thyroid hormone, that is anti-TPOs. That's the thing. Or intermittent T4 therapy or T4 overdose. This is a T4 overdose. Also, drug interferences. This is again amiodarone, heparin, beta blockers, steroids, like anti-epileptic like Aptoin. There are many drugs that have a powerful tool that reduces T3, and many times it may increase free T4 as well as TSH. So when you find there is an increase of TSH, raised TSH, and slightly increased T4, try to exclude, ask the patient about the story of, are you taking any beta blockers or calcium channel blockers, or are you taking dexamethasone, or are you taking Eption like anti-epileptic drugs, like lithium, also some lithium, very important, can also produce this. Then comes the other situation where TSH is decreased and T3 and T4 is raised or within range. Again, as I mentioned, low TSH, just like low T3, low TSH is also isolatedly seen, especially in the old age people. It may also associate with the non-thyroid illnesses, especially anterior pituitary, hypothalamic situations, even subclinical hypothyroidism. Suppose, again, if all these three, T3, T4, TSH, all things are decreased, then imagine this is a central hypothyroidism and or recent treatment in hypothyroidism, which means patient has been given neomercosol, asked to start medication, but they made a check very recently because all of a sudden there will not be much change. So there is a change in the T3, T4 and TSH. That is the central hypothyroidism or hyperthyroidism. Then again TSH is decreased and T3, T4 is raised, these things. I think this is enough at this moment back to understand the case. So this is one case. Now, coming to the third case. This is again another different. A lady aged about 16 brought complaining of multinodular goiter involving both the lobes and isthmus and thyroid. So she went to endocrinologist, and endocrinologist told that you have a multinodular goiter, and her T3, T4, TSH is normal. So doctor told you may live with this, or you can start some medications. So they recommended her for a surgery. So they have decided anyhow, and they have decided to do a review of the same after 2 years. So after 2 years of the same patient, multinodular goiter involving both the lobes and isthmus of thyroid size increased compared to the old scan. Again, her T3, T4, TSH falls within the normal range. You see the TSH is 0.477, 1058. T4 is also normal and T3 is also normal. The same age. So what has happened? She had a nodular goiter A goiter and biochemical thing are a separate entity sometimes. What makes the goiter? Goiter is, we can say, it is a hypertrophy of the gland. Any gland can get hypertrophy. Any gland can get hypertrophy. Suppose if I go for a higher altitude trekking, for example, if I go for a Kailas Manasarovar trip, their oxygen level is really low. So I have to make a parikramanam all around. Since the oxygen level is very low, I will start breathing very fast. And my body demand more and more blood in my periphery because I'm walking and making a circle with a very, very cold climate. Not at now. Now Kailas is not open at this climate. Maybe heavily snowing. I'm speaking about in August or September, where summer may be there. So what happens is that my left ventricle gets hypertrophied because my heart has to pump faster. I will have a LVH, left ventricular hypertrophy. If I check the ECG, if I see the limb bleeds of the V4, V5, V6, there may be change suggestive of LVH. But is it a problematic? No. It is absolutely physiological. And as soon as when I come back to my land, Kerala, maybe after many weeks, slowly my left ventricle hypertrophy may come back to normal. It takes a long time. Not as fast as enlarged. It takes longer time. It is the same story for the goiter too. There was a situation where body was strongly demanding T3 and T4. But it was not able to produce the level what body expected. So since there is a strong demand, the stroma cells of the original cellular part of the thyroid gland try to expand like a hypertrophy, try to expand so that it can produce more and it can store more so that whenever there is a demand comes, it can deliver. So this physiological, maybe physiological or a pathological enlargement developed in the neck are identified as a goiter. But maybe that situation disappeared after some time, just like I came back from Parikramana back to Kerala. But that enlargement which happened in the neck may persist for years together. Because once a gland becomes enlarged, it takes long time to distinct. But what is very important is that it should be regularly monitored and make sure that it's not enlarging. But look at this case. She hasn't taken any care of the thyroid gland, even though she had a nodular goiter. And she reviewed 9/10/2015 and 10/10/2017. She reviewed and there is an increase in the size of the gland, which means that in these 2 years, she had some biochemical changes of the thyroid hormone. But when she came in the clinic, she says that, doctor, I checked the thyroid status hormone. Everything is normal. What shall I do? So such cases, we have two questions in front of our mind. One is that what medicine we should give so that she should have a stable hormonal level. One. Second thing, do we try some medications that can be applied in the neck, at least to prevent further enlargement of this? Or secondly, do we suggest a surgery for removal of this? Generally, I strongly recommend to the people, let us start some external application, as I mentioned in the last presentation, some external application in the neck, which will be very much helpful, maybe reducing slightly to the size, but mostly it will support not to enlarge. And moreover, We may use some of the medications like Panjarara Gugulu or Hamsapatyadi Kashayam, whatever, that can keep the metabolic situation at its best. So that is the another interesting thing. Now goes to the another case. Another case, a female aged 40, brought with a diagnosis of well-defined hypoechoic nodule 2.3 into 1.3 in the right middle extended to the isthmus. So left lobe is only 0.5 to 7, in the middle lobe no enlargement little short. And when she has been checked, the T3, T4, TSH, everything falls under normalcy. And so this is happened in 2015. And in 2017, she repeated and found that there is a mild thyroiditis, 2 benign nodules in the right lobe, small, tiny benign cyst in the right lobe, non-specific bilateral cervical lymphadenopathy, submandibular glands early adenitis feature. Look at this. Here the situation is changed. Here it was small, but here this is suggestive of there is no thyroiditis at all in 2 years, 2015, and there is no significant change in the hormonal level ever here in 2017, but still there is a mild thyroiditis. So again, she is strongly recommended to take Ayurvedic medications, and she is improved drastically, and this thyroiditis symptoms disappeared. This is not a very common presentation, because when you have a T3, T4, TSH level falls quite normal, it is very rarely to have a thyroiditis, because if there is a thyroiditis, definitely we are expecting some alternation in the T3 level, which was not at all seen here. So this is a different presentations. So this way there are different presentations. So now come to another some of the important things is we have seen some variations of hypothyroidism, and also I would like to speak also hyperthyroidism and its management, which were not discussed thing. As I mentioned in the before, when we have hyperthyroidism, what situation we have is an excessive circulating T3 and T4. So most commonly caused for maybe the Graves' disease or toxic multinodular goiter or toxic adenomas are there. Or as you know what happens in hyperthyroidism. Many times this hyperthyroidism also happens due to poor management of hypothyroidism. What happens that they will have hypermetabolic state, hypersympathetic activity. So you can imagine there is a situation of anxiety, irritability, tremor and nervousness, tachycardia. Many times this hyperthyroidism mimics some psychological problems. People may misunderstand it as a mania. People may misunderstand it as a schizophrenia. People may misunderstand it as some of the unusual presentations of a person. Maybe this type of people may get rejected from the society, or maybe sacked from the job, or they may have to fight in the roadside for different reasons. They get irritated very fast. So feeling hot, voracious appetite, fatigue, weight loss, very, very common. So whenever you get somebody saying that they have a weight loss without any proper reasons, diabetes, hyperthyroidism, malignancies, tuberculosis, these are things comes in our mind. So hyperthyroidism also should come. Shorter menstrual periods, exophthalmos, very, very common. Again, as I mentioned, like the case of goiter, exophthalmos is also a very common thing. Once it manifests, it takes long time to go back. Many times it will not go back at all. Hair loss, sweating, these are things. So Adivruttha Pitta Lakshana, Vadavardhi Lakshana, or Atyagni Roga, like Agni Atyagni is a thing. So we have lot of Pitta symptoms, Krodha, Irshya, these type of Pitta symptoms. Anxiety, nervousness, tremor, tachycardia, and there are some descriptions like Bhasmaka Roga, Kapashosham, Pitta Kopam, Vadanubandha problem, and Sthana Samshayam to Pachamanashayam. Then the Jadragni will be too much, burning food with no time. Trishna, Daha, Kasa, Murcha, and Ojokshaya, death can also happen. Yes, it can also rarely hepatic toxic. Graves' disease, when it becomes very toxic, it can end up the person's life. So there is a beautiful description I read in the books. Agnir Aharam Pajadi, Doshan Pajadi, Dhadun Pajadi, then Murtyum Aneti. So that type of Agni is there. What we should do such cases. So we have extensively discussed in the hypothyroidism, but it's also important since I am speaking on thyroid seminar. Hyperthyroidism should be treated very well. But practically speaking, treating hyperthyroidism is easier than hypothyroidism because controlling Pitta, even though it is the worst thing, but controlling Pitta is easier than controlling Kapha and Vata. Because we have enough medication that can bring Pitta Shamana faster, like Guluchadi Kashayam, Chari, Bhushira, Chandana, Shadavari, these type of things. Even Dadimadi Kridam, which I mentioned in hypothyroidism, also very effective because that combination, Dadimat Kudabo Thanyat, Kudabadram, Kalambalam, that yogam is excellent. So these are the things we already discussed some of the management last class. Kshirabhagam, Parushagadi Kashayam, Moolagadi Kashayam, Nirgunyadi oil. This is again Nirgunyadi oil which I forgotten to mention in last presentation. Nirgunyadi Valichana or Nirgunyadi oil. The coconut oil are also very good in hyperthyroidism. Again, Atyagni and Mandagni take care of Yogavahi Vayu. This is very important in the management of thyroid dysfunction. And there is also some ideas are taken from Daha Jara and Shida Jara. Daha Jara and Shida Jara versus how to manage this thing. So as I mentioned before, when we have, there is some spelling mistake, sorry, in the Pitta. So Pitta association, there is a hyperthyroidism, so Videchana will be better, and Kapha association, you have Vamana better. I mentioned these things in the last, but I'm just putting back again for the point of discussion for reminding you. And many times, correct the Agni and do Vatanulomana and Koshta will be very, very important. To that, some of the medications, especially in the hyperthyroidism, some of the medication like Trivrt Leham, that is the Ashtangardaya Kalpasthana Yogam, Trivrt Kalka Kashaya Sadidasa Siddhohima, Yoshatrajana Samyukto Lehyam Hridyam Virechanam. Some company produces under the name of Hridya Virechanam. So it is the Trivrt Lehya. Then Kalyana Gulam, everybody knows. Then Avibhatti Churnam. Sarve Samasam Siddha, Chaudrena Gudgi Kuda, Avibhatti, that one. without creating vipat. No complication powder. That is avipatti churna. No vipat. No complication. And again, some of the important thing like Shatavari Kshirapakam, very, very excellent. In many of the Western countries, since I have been speaking to many Western country people, it is very difficult to get many medicines there. But asparagus, many varieties of asparagus is available in that country, especially in the European countries. Many varieties of asparagus are available. So we strongly recommend people to take Shadavari Kshirapaka.